Guys, so tonight we're going to talk about arterial versus venous disorders. And so this is going to be a shorter version. I have a longer vascular disorders video that if you want like a really deep in-depth going into the ins and outs of vascular, that would be one to watch if you feel like you're just starting with this. But if you're just kind of skimming over the surface and kind of seeing if you know the overall concepts, this would be a good video to watch. You could always start with this one, and then if you need to go more in depth, you can kind of pick through the other one as well. So let's start kind of breaking these down. When you hear arterial, you should have some alarm bells going off in your head and saying, okay, this is the serious one. So like the main arterial disorder we talk about is PAD. So we always remember PAD is BAD, or it's a really bad problem. And remember, that's not man, that's the simple nursing that came up with that one. But effectively, there's a really big problem here where there is lack of blood flow. And so this is like a life or death, could be an emergency kind of problem. So anytime you're kind of hearing something arterial, remember that's our fast flowing choo-choo train blood. It's going quickly to the tissues to drop off oxygen so that I can get perfusion. So when there's a problem with this system, there's an ischemia problem or a lack of blood flow, which can lead to tissue death. This is a big blockage. This is ischemia. This is we're worried about like loss of limb and some real serious problems with this. Whereas when you hear venous, there's still a problem here and there could be very serious complications, but it's usually not immediate life threatening. This is a pooling problem. So whereas arterial is a problem getting blood down and getting that blood flow to my periphery, venous is a problem having enough pump to pump my blood up and bring it back to my heart. And while that seems like it's a big issue, it's not as big of a problem. I'm still getting blood flow, it's just not pumping as well back up. And there's pooling of blood in my legs, which can lead to some problems. Like anytime you hear pooling, you should think blood clots. So let's kind of break down some of the major diseases that are within each of these. So remember, we said arterial or PAD. This is the serious ones. This is the PAD is BAD. So usually you're going to see PAD in the legs and think no flow to the toe. You like it? So yeah. So effectively, they're not having blood flow down into their lower extremities. Pretty much what's happening is there's a very narrow artery kind of flowing down towards the toes. And so obviously if there's less openness, or if there's more of a narrow artery, I can't get flow down to my toe. And so the problem there is that eventually if I can't get flow, then that's creating a blockage where eventually that tissue can die because it's not getting the oxygen it needs. These patients are going to have pain with activity. So think like chronic stable angina, where that patient was up, walking around, maybe they were playing golf or exercising and they started to have chest pain. That this patient's the same, except their pain is in their leg. And they usually complain of that sharp, sudden pain, especially with exercise or exertion. They may also have signs of decreased blood flow. So they may complain of paresthesias like numbness and tingling, and they can also, get ulcers. And the big differentiation for arterial ulcers is usually arterial ulcers are on the toes or the bottom of the feet, the general appearance of them is kind of like a round appearance, versus kind of like a wavy or irregular border. They usually have a circular border for those ulcers. The other thing you want to remember for PAD is it's also the only way that you can ever have to permanently stop shaving your legs. Because you're not getting blood flow, you lose your hair down. You lose your hair down there. Sounds kind of bad, but you lose your hair on your legs often because you're not getting blood flow. So there's nothing to help with your hair growth. So their legs are usually pale, shiny, and hairless because you're not getting good perfusion down to your lower extremities. You should expect that their foot pulses, which is the dorsalis pedis and the posterior tibia, are going to be weak or absent. And that's considered an emergency. You definitely need to contact someone about it when they're absent. And then the end result, what I'm really worried about happening here is that they're going to lose their limb, because pretty much it gets to the point where that artery gets narrower and narrower to the point where, again, there's no oxygen, there's no blood flow. And so that my tissue starts to die because it has no other choice. It's not getting the nutrients it needs. So what do we do? So the key things for PAD are going to be meticulous foot care, making sure that I'm teaching them all the same things that I teach a diabetic patient about keeping their foot moisturized, making sure to wear well-fitted shoes, avoid temperature extremes, the hot and cold temperature extremes, making sure to check their feet daily, clean them daily, and make sure that as a whole, they're never going barefoot or doing other things, and really looking to prevent that trauma in their foot. They may need surgery to unblock this block, because remember, this is effectively like a blockage. There's a narrowing of that artery. And so sometimes we go in and we clean out the plaques. Sometimes we go in, put a stent in. Sometimes we go in and put like a graft or open up the blood vessel a little more. And then sometimes we do what's called a FemPop, or femoral popliteal bypass graft, which is where literally we create a detour. Blood's not flowing through this artery, so I'm going to create a new blood vessel that's a new pathway to help kind of divert some of that blood so that it can actually get flow to my lower extremities. The key assessment for these patients is going to be a very good neurovascular assessment. So I would review your 6P, I would review your 6Ps and 1C in order to kind of look at that and see, okay, what am I going to need to know as the nurse? Because those neurovascular assessments are going to help tell you if the patient's getting better or worse, because a lot of that's what their symptoms are. Because remember, this is a perfusion problem. So the best way to measure perfusion is a neurovascular assessment. If you don't know what that is, I would definitely look more into it. I'm not talking about a neuro-brain assessment. I'm talking about this is like pain, sensation, movement, a lot of these things. And we're going to be looking in that extremity, that distal limb, the one that's most affected by this. I'm going to teach them energy conservation techniques. So to balance rest and activity, while walking is the best thing chronically for PAD, they are going to have to learn how to rest sometimes and not overexert themselves. Pain relief is also key with these patients. So they can take medications that are specific, just like there's nitro for the heart. There's also medications that are vasodilators that are going to help to open up specifically those leg arteries. That's going to help with some of that, kind of like that leg angina, as I describe it, pain that they're having. And then take care of them blood vessels. So all the things we can do: manage their hypertension, manage their diabetes. They have to stop smoking. Smoking is probably one of the worst things you can do for your blood vessels. And making sure that we're doing everything to prevent like more plaques from building up. But whatever we can do to protect and ensure the integrity of those blood vessels, we want to definitely strive to do that. So now let's look at venous problems. And there's three main venous problems. There's varicose veins, which is where there's too much pressure you get these tortuous veins. It's actually literally like a hemorrhoid, but it's on your leg. There's these kind of fat, dull, achy veins is what it feels like. It's like a lot of pressure. And so for varicose veins, they're usually what we call self-limiting, which means they don't necessarily cause problems aside from the discomfort. And they're more often happen in women. And so a lot of times there's the cosmetic thing that women don't like the appearance. And so varicose veins, you really need to manage your risk factors like obesity. You also can manage, a lot of the work that you do. So sitting or standing for too long can increase your risk of varicose veins. So what you want to do is try to manage those. There are cosmetic procedures that can remove the appearance of the varicose veins, but if you still have all of the risk factors, those can come back. So, I didn't cover this yet. I was going to save it more for the end, but I will say, for arterial, I always remember for arterial, make an A. So arterial, think like this is like the letter A. All of your interventions for arterial is going to be about legs dangling. So remember the 3 Ds for arterial. So the 3 Ds that you want and it's all the same thing. It's dangle, or put your legs down, or dependent. So if you see if you see on a test question, it's talking about down, dependent, or dangling. That's something you want for arterial. I want the legs down in order to help to increase my blood flow. Where now we're getting into venous problems. Venous, like a V, make a V. And venous, we want the legs up. So elevation helps. The 3 things that help with venous problems: elevation, compression, and activity. And so that's going to help to relieve some of that. And you have to think, how that makes sense. So for arterial problems, my problem is I'm not getting blood down. So effectively, by altering what's going on in my legs, I want to have gravity help me, and also try to really get to the bottom of the problem. So my problem in arterial is I'm not getting good blood flow. And part of that, is because I have really crappy blood vessels. But also, like, if I'm sitting there and I have my legs elevated and my body's already working to fight, think of kind of like that extra resistance that it has to overcome with that. So if I dangle my legs or put them down, or it's also known as dependent, if you see the word dependent, it means down. If I dangle my legs, put them dependently or down, then I'm going to help to overcome some of that gravity and I can get better flow to my legs. Whereas when we talk about venous problems, we like the elevation. So when I elevate my legs, if I'm sitting there laying in the bed and I have my legs up, it's going to help that fluid to run down my legs and then go back into my body, with the help of gravity. And then compression and movement helps, because remember I said in venous, the problem is there's pooling of blood. My leg pump in my legs is not pumping to get the blood back up to my heart. And so I need that extra squeeze. So a lot of what I can do to help prevent problems that are venous and prevent that pooling of blood is to wear compression stockings, use SCDs in the hospital, and even better, getting up and walking around is it's a natural squeeze that's going to help get blood back up to my heart. But anyway, let's get back here. So there's 3 venous problems: the varicose veins, which are these, tortuous blood vessels. And I was talking about how key it is that we do things to prevent it. So remember I said the 3 things we want to do to help prevent it. I need to get up and moving. I need to use the compression devices or compression stockings to help to prevent that and add that extra compression. And then also elevation is very helpful for preventing this pooling problem that I have in venous. There's also phlebitis, and this is usually referred to as thrombophlebitis. It's where I get irritation because I usually have like a peripheral IV in, and then what happens is a clot, not an actual blood clot, but I don't want to get myself tangled in my words, but effectively what's happening is there's irritation of the blood vessels because that catheter is inserted, and the lining of the blood vessel gets irritated. Platelets start to stick, and they cause a problem. And the problem is not the blockage, the problem is the inflammation that leads to irritation. So I have here pain and inflammation, I need elevation. So this is when you go up to an IV and you look at it and it's red, you touch it and the patient says, ouch, you're flushing it and the patient's like, oh, that really hurts. And there's something not right there. It's actually the blood vessel is inflamed because there's been damage to that wall. And then your body's trying to form a protection or kind of cover up that problem, but it actually ends up just leading to more problems. So for patients that have thrombophlebitis, again, this is usually related to IVs. What we want to do is we want to do the elevation. So we're going to raise it because there's inflammation. We might give them anti-inflammatories like NSAIDs. And then we also want to put a warm, moist application or pack on it. We want to remove that IV too, by the way, and make sure that IV is out so that it's not going to be causing any more damage. Because effectively we're trying to remove the irritant, and so something happens. Now, this is not to say that every time you insert an IV, this is going to happen. Just sometimes this happens. It's a chain reaction that gets set off. So remove the IV, elevate it, anti-inflammatories, and you want to put warm, moist heat on it. Now, it might seem counterintuitive because it's like, oh, it's painful, put some ice on it. But ice vasoconstricts, and we want nice and open blood vessels, and also it helps decrease that inflammation. So last but not least, there's blood clots. And this is an actual blockage, and it doesn't mean it's 100% blocked, but it's just kind of like with, it's like, hold on one second. It's like, we talk about there's a blockage in PAD that leads to ischemia. This blockage actually leads to inflammation. So effectively, when there's a blockage or there's plaques building up and stuff in my arteries, that's like a problem, not like a problem, that is a problem because, effectively, there is less space for blood to flow. It's literally blocking the space. The problem and that's in arteries. In arteries, plaque builds up and then platelets come hang out, and there ends up being this big blockage or less blood flow through that artery. But the problem with clots that end up in your veins is that they lead to inflammation. The veins are very sensitive, and they're like, oh, what's this thing? It's tickling me. And so it gets inflamed and it gets very irritated. And then that's where you end up with a lot of symptoms of that blood clot. And so my goal for blood clots is not actually, because once I have one, I usually do not get rid of it. We'll talk about this here in a second. I usually can't get rid of it, but what I want to do is not create more blockages. So we talked about PAD as the big arterial problem. Let's talk about DVT as the big venous problem. So it's really important for you as the nurse to know who is at risk for DVT, what are those people that are going to be more at risk. And it's going to be people that are immobile. It's going to be people that are on hormonal or other treatments that could cause the other medical conditions that could cause their hormones to be off. People that are pregnant are at higher risk. And then there's also, people that are dehydrated or do not have enough fluid intake, because that kind of creates more thicker blood. Anything that creates thicker blood, we're going to be worried about people with certain heart rhythms like atrial fibrillation, anyone who pools blood. So, we talked about varicose veins, and when there's like pooling of blood in the lower extremities, we're really going to be worried. Anytime you hear pooling, think blood clots. So these are just a few examples, but it's really important for you to understand who's at risk. And there's the Virchow's triad. That's the triangle of all the factors that lead to people being at risk for blood clots. I would know that very well because it's very important. And NCLEX loves to test over that kind of stuff. But it's more important to kind of really focus on to understanding. It's not just about memorizing a long list of here's all the risk factors. Really try to understand like, okay, what are the pieces, and try to look at the bigger picture. Like, okay, people that have this, like in general, like this general characteristic are more at risk versus just trying to memorize a list of conditions. Because then if you get on the exam and the condition that you memorized is not on there, then you're going to get stuck and be like, I don't know. The big thing we worry about with DVTs is going to be of course, it traveling somewhere else. So what the big thing is we want to try to contain it. So we don't want to do anything to irritate or agitate it. So for example, like if I went in to take care of a patient and a nurse told me, hey, they have a blood clot in their left leg. The thing I would want to make sure is I'm not going to put a SCD on that leg. I'm not going to put anything that's going to squeeze that leg. If they have a clot in there and I'm squeezing it constantly, it's really pretty much asking for that blood clot to move. And that blood clot, if it moves, remember it's in the vein, so it can go back to the heart. It can end up in the lungs. It could end up in the brain. I definitely don't want it traveling anywhere. So you really want to be watching out for those, possible complications that might happen if that clot travels. Like I mentioned before, we usually don't bust the clots because usually they're not causing enough of a blockage or a problem to bust them, but we want to decrease them from forming more clots or, kind of adding to the fuel to the fire of that's what's already there. And, we do this through giving them, most patients are on anticoagulation. We want to manage their painful symptoms. So a lot of these patients, usually what they complain about is they have a unilateral or one-sided red tender leg. They may feel like a really kind of like with the varicose veins, they might feel a really deep fullness or heaviness to that leg, and they can have some pain with that as well. So I'd want to manage that pain and inflammation. Like I mentioned, we want to prevent it from traveling. To a different place. And when it's possible, let's decrease those risk factors so it doesn't happen in the first place. Like, so if someone's really high risk, like maybe they're immobile, like encouraging exercises or we have everyone on that DVT prophylaxis. And that can be one of two things. So everyone in the hospital is at risk, for getting a blood clot because they're in the bed and they're immobile. For the most part. Even if you're someone who's up walkie-talkie, you're still probably not as active as what you are at home. So you're at higher risk. So what we want to do is we either want to put on SCDs on them, those leg squeezers, or we want to put them on a anticoagulant like a heparin or an enoxaparin, Lovenox, that's going to help to decrease the risk of forming blood clots. So effectively, when you're taking care of your patients, it's actually a part of my charting on a day-to-day basis to go in and put what kind of DVT prophylaxis does my patient have, because every patient should always be, we should be doing something to prevent clotting in them, because pretty much being in the hospital is like signing up for being at risk. That doesn't mean when these patients go home that they're going to need to be on these things, but while they're in that state, they may, or they should. And then education is important because a lot of these patients, like I said, are going to be on anticoagulation, especially if they have a blood clot. And even if they don't have one, if they're on these anticoagulation, I need to teach them bleeding precautions and teach them ways to be safe, what kind of findings to report to the doctor, especially like any signs of bleeding or changes that could indicate that they may be bleeding inside. I want to make sure the patient's aware and all those things to know how to be safe so that they don't end up having injury, the kind of activities and things to avoid. The other thing I want to mention here is that DVT can also be known as VTE, which is venous thromboembolism, and they're both saying the same thing. Deep vein thrombosis, what do you call that? Saying that there is a clot in the deeper or the more larger veins, whereas VTE, venous thromboembolism, means that, hey, somewhere in my venous system, there is a blood clot. It's more of like a global thing, but just know that these words can be both used. They're pretty much saying, hey, there's a blood clot. And that's what you really want to focus on. So to kind of sum up, just I kind of broke these down, is that we have PAD, that's that really big scary, remember it's BAD, really bad disease process, there's this lack of blood flow, which can lead to ischemia, loss of limb. We really want to teach the patient to take good care of their blood vessels. They may need to take some medication for that intermittent pain they're having, that intermittent claudication, which is pretty much they're having pain when they're exercising and doing things like that. So we really want to encourage them to, kind of mix up their rest and activity, take medications as needed to kind of vasodilate and open up some of those arteries. And then they may need procedures and other things to help manage those blockages. Because remember, that's the BAD one. They're having blockages to their toes and their feet, and they may not be able to keep their toes and their feet if they don't get that flow restored. And then we have venous problems, which are more, there's a pooling problem. They're more at risk for blood clots. And then, of course, blood clots themselves. We're worried about, that blood clot traveling somewhere else. And we want to prevent more clots from forming. So this patient's going to be on anticoagulation, and we want to help support them in taking that medication safely. And then, of course, first and foremost, we'd love to prevent all of these with good education, good cardiac diet and cardiovascular education in general, and decreasing those cardiovascular risk factors. And yeah, so if you haven't noticed as a whole, a lot of vascular disorders is looking for who's at risk and trying to mitigate that risk. But hopefully this helps to break down a little bit about that difference between what's an arterial problem, what's a venous problem, and what are some of the basic things we're going to do for them. Like I said, this was a very quick overview. If you want more details, you can look into my other video that goes more specifically into what's the deal with vascular disorders in general, and what are those really specific teachings and other interventions we want to do as the nurse. Thanks, guys. See you next time.